Hey, welcome back to Not So Complicated, and today we are doing how to read a chest x-ray like a radiologist. Whether you are an MBBS student or MD student or any aspirant or a doctor or a patient, this video is for you because we all know that it has been a serious problem to not to be able to read a chest x-ray, right? So I provide you a detailed step-by-step guide. Let's begin without further delay. So we do in steps. Step 1 is technical assessment, step 2 is systematic interpretation, and then step 3 we will talk about correlated morbidities, right? So in step 1 we do technical assessment, where we approach by a right method. R is rotation. We have to check whether the chest x-ray is ideal for our examination or not, right? Technically. So we have to check for rotation, inspiration, position, and then exposure. We will talk about each of these, right? So at first it is rotation. So what is rotation? A patient should be centrally placed when a x-ray is done, right? Check if the patient is centered or not. How do we measure if the x-ray is centered or not? We measure the distance from the medial clavicles to the spinous processes, and that should be very much equal in both sides, right? So this is the spinous process right here, and this is the medial clavicles of both sides, and we measure the distance between them. Then it should be equal, and if it is asymmetrical, then it suggests rotation. That is right clavicle, for example, right clavicle farther from midline if it is rotated right. That is actually what happens in a chest x-ray, in a rotated chest x-ray actually. And a rotated chest x-ray may falsely widen the mediastinum, mimicking aortic dissection. This is an example case. So a rotated chest x-ray is not an ideal chest x-ray. We have to look for that, right? So there is an example. You can see clearly the asymmetry here. You can see the asymmetry of this long fields too, right? And in this case, the vertebral asymmetry, even the chin of the patient is seen in here. So this is very much wrongfully done x-ray. We had to redo the x-ray if the x-ray finding is like this, right? So the other step is that inspiration. We have to do the x-ray in full inspiration to count the ribs, and also to do the full long field examination to not miss any like lesions and not to be confused with any lesions, right? So in full inspiration, how do we say that if a x-ray has full inspiration or adequate inspiration or not? We have to count the posterior ribs above the diaphragm, and that should be 9 to 10 for adequate inspiration. Let's count here. 1, 2, 3, 4, 5, 6, 7. You can see here 8 and 9, right? In both sides 8 and 9. So this is a case of adequate inspiration, right? So what happens if there is poor inspiration? That is less than 7 ribs is like called as poor inspiration. And what actually happens is that it crowds lung fields, mimicking consolidation as in pneumonia. So a COPD patient with hyperinflated lungs may show 11 to 12 ribs. That is a case example, right? So let's talk about poor inspiration. Here you can see, you can count the ribs here. 1, 2, 3, 4, 5, 6. So not even 7 ribs. Same is the case here. So not even 7 ribs, and this is a case of poor inspiration. Here you can see that it is falsely producing consolidation. That is actually diaphragm in this case, right? So this consolidation can be confused with pneumonia. So we have to actually make sure if it is a consolidation case or actually a pneumonia. So we have to be ensured that chest x-ray is done in full inspiration by counting the ribs, right? So let's talk about position. Another position is like another term is position here. X-ray is done either PA or AP or lateral view for many different functions, right? So PA is made like done over AP because AP has a flaw. That flaw is this cardiomegaly, false cardiomegaly. Why? So what is actually PA projection? PA is that the patient is facing towards the X-ray film, right? So the X-rays are transferred from X-ray tube from posterior aspect to anterior aspect, right? That is PA projection. And in AP projection, the patient is facing towards X-ray tube, not the X-ray film. So the rays are passing from anterior aspect to the posterior aspect. So heart is a little bit nearer in AP projection than in PA projection. So little bit nearer to the X-ray tube. So what actually happens is that it can mimic a false cardiomegaly, right? So that is why PA view is actually preferred over AP view. And then lateral view, we'll talk about that. So PA is standard, scapula outside long fields in PA views, and also then AP is often bedside is done in often bedside, and that magnifies heart. And lateral view assesses retrocardiac space, that is beyond the heart, what is beside the heart, right? So PA is standard because scapula are also outside long fields. Let's see here, how do we differentiate if the X-ray is PA view or AP view? Actually, if there is no any term written in an X-ray, you have to consider automatically that the X-ray is in PA view, and if it is in AP view, the X-ray will be written as AP view. So that does not bring any confusion. But if there is any confusion, so let's differentiate between them. So CSR assessment should be done actually. So in PA view, we see clavicles in the lung fields. We can see clavicle in the lung field. This is the apex of the lungs, and still we can see the clavicles here, right? And similar is this for the another side. But in AP view, we do not see clavicles in the lung field because it is above the apex actually, or in the border. And in scapula, we had talked about it earlier. Scapula is outside lung fields in our PA view. There is no scapula in lung field, like the scapula border, inferior border also. But in AP view, we can see scapula, but here it is very poorly made, right? So we cannot see here, but we can actually see the borders of scapula in AP view. And in ribs, it is very easy. In posterior anterior aspect, we can count the posterior ribs, and in anterior posterior aspect, we can count the anterior ribs so easily. So this is the lateral film here, this is heart, and you can see whatever going beside the heart in this region in lateral chest X-ray. So this is for the assessment of retrocardiac space, right? So let's talk about the last step in technical assessment, that is about exposure. So we have to ensure that the X-ray is properly exposed, right? It should not be overexposed or underexposed. So how do we say if an X-ray is properly exposed? We can say, because we have to count the vertebral bodies behind the heart should be faintly visible, very faintly visible, T4 to T6. That is an ideal exposure, right? So, but if there is underexposure, which is too white, you can compare it with a photo, mobile, like photo you take from phone, right? So if it is too white, you cannot see vertebrae. You cannot see any vertebra here, right? You cannot count or see any vertebra. So that is underexposed case, and it hides long details, right? So that is why this is a problem. And in overexposure, as in this case, even the ribs are obscured in this case, right? It obscures bones, and you cannot see what actually happens, right? That is why overexposure is not also ideal. So in underexposed chest X-ray, may miss a subtle pneumothorax. Here you can miss pneumothorax because everything is whitish in this case, and here you can falsely take pneumothorax because even the ribs are getting obscured here, right? So exposure is also a thing that we have to consider. So RIPE method is done, and then this is a homework for you. You can comment down what are these technical assessments, like what are the problem in these X-rays. So you can comment it down, right? Let's talk about the step 2, where we do the systemic interpretation by ABCDE approach. A is airways, B is breathing, C is circulation, D is diaphragm, and E is everything else. Let's begin from airways. So actually what happens in airways, that we have to examine the trachea, carina, which is the bifurcation point of the trachea at T4 or T5 level, and bronchi for position, patency, and abnormalities. That is what we assess in our airways, right? So let's talk about trachea first. So trachea should be in midline position. So any deviation from the midline position is a problem here, right? So deviation suggests dextrocardia if it is right-sided deviation. Dextrocardia, in dextrocardiac cases, even the heart is on right side. Isn't that amazing, right? And in situ, like situs inversus cases, your entire right-sided organs are in the left side, and left-sided organs are in the right side. So in mass pushing away, or tension pneumothorax pushing opposite. Here you can see the example. This is a case of tension pneumothorax from a trauma or any underlying reason. But this is pushing this trachea here. You can see this is left-sided tension pneumothorax pushing trachea to the right side, right? That is the deviation. So a right-sided tracheal shift in a trauma patient suggests left tension pneumothorax. That is how we assess the chest X-ray. Let's talk about like this is actually how we read in a normal case. This is an ideal normal chest X-ray, and this is the trachea here, right? This is the aortic knuckle or nerve. This is very normal, and it can get dilated in certain specific conditions like pulmonary hypertension and other reasons, right? And here you divide the trachea in T4 to T5 level. We have to count the vertebra here first, and then we divide, right? So it is a carina. This is the bifurcation point. It is carina, and this is right main bronchus and left main bronchus. Let's talk about carina. So it is located at T4 to T5 level, where the trachea bifurcates, and the angle of carina is normally 90 degree. But if there is greater than 90 degree angle of carina, so it indicates left atrial enlargement or lymphadenopathy. So that is very clinical pearl, very important clinical pearl. Like right here, you can see the carina is almost 102 degrees, right? So it indicates that there is left atrial enlargement, left atrial appendage. You can see this is due to the enlargement, right? So a widened carina in a heart failure patient may reflect left atrial dilatation. That is a clinical finding for you. Let's talk about bronchi now. So bronchi, right main bronchus is wider, shorter, and more vertical, predisposing to foreign body aspiration. How do we remember? Like there is a mnemonics called WIBE. Yes, right? Vibes. Vibes are always right. That is how you remember. Vibes are always right. So WI is wide, BE is vertical, and S is shorter. So right bronchus is wider, vertical, more vertical, and shorter, right? So it predisposes to foreign body aspiration. Look for intraluminal masses or narrowing. This here you can see. These are intraluminal masses, right? This can be an aspirated P0 in a childhood, in child x-rays, right? Or right main bronchus opacity in a child suggests an aspirated P0, and this also suggests an aspirated foreign body right here. It is present in both bronchi, right? So right main bronchus is why more predisposed for lesions. That is how we complete our airways. Now let's talk about B, that is breathing. In breathing, we have to assess lungs and pleura, right? We have to assess lung fields, pulmonary vessels, and pleural spaces for pathology. Let's begin from lung fields. And inside the lung fields, we have to assess consolidation and other reasons that we will be talking in a few minutes, right? So we have to compare both lungs for symmetry first. It's like we have to do the technical assessment, and if the chest x-ray is ideal, then we have to check for the systematic interpretation, right? So let's see. Wow, how a consolidation appears. Like it increased opacity is consolidation actually. So that happens in pneumonia. As you can see, this is a case of right middle lobe pneumonia, right? Lobular pneumonia actually, right middle lobe. So here you can see clear cut consolidation, right? Air bronchograms can be filled, like air-filled bronchi against opaque lung confirm alveolar filling. That can happen. And in example cases, right lower lobe consolidation with air bronchograms in febrile patients as bacterial pneumonia. But in this case, this is this is right middle lobe pneumonia, right? Right middle lobe pneumonia. So that is how we assess consolidation. And the other thing is nodules and masses. We have to assess that too. So if the opacity is less than 3 centimeter, that is nodule. But if it is greater than 3 centimeter, that is mass. We have to remember like that, right? So here you can see the nodules, right? It has a demarcation, and the demarcation line is speculated. We have to suspect malignancy. But if it is clearly demarcated, this is a case of benign tumor or like that, right? So speculated margins suggest malignancy. A 2 centimeter solitary pulmonary nodule in a smoker warrants CT for lung cancer evaluation. Okay. That is how we assess our nodules or masses, right? So another thing we have to assess in lung fields is lucency. Lucency is that dark areas may indicate pneumothorax. No lung markings are there in case of pneumothorax, or emphysema, hyperinflation and bullae. In emphysema, that can cause hyperinflation or bullae, and in severe cases of emphysema, there are subpleural blebs actually formation, like bowels of air, subpleural bowels of air, and when they rupture, they can lead to pneumothorax. So there is hyperinflation in cases of pneumothorax and severe emphysema right here like this, and in hyperinflated cases you can count almost up to 11 to 12 ribs actually. You can count that, right? So that is how we see for lucency. Dark areas, because here is extensively more amount of air, right? So a sharp long edge with absent markings in a young male suggests spontaneous pneumothorax. It is very easy clinical pulse. The another thing we access is pulmonary vessels. As we had talked earlier, lung fields we had done, consolidation, nodules and lucency, and now we will talk about pulmonary vessels and then pleuralis vessels. So let's go to the pulmonary vessels. So what are pulmonary vessels? Like we do hilar vessels to taper peripherally. It should taper peripherally. Tapering means like this is hilar vessel, but it should taper like this. It should taper peripherally in normal cases. Enlarged hila either suggests there is pulmonary hypertension or there is lymphadenopathy. You can see this is the hilum. These are the both sides hilum, and this is the case of lymphadenopathy right here. We have to clinically distinguish whether it is pulmonary hypertension or lymphadenopathy. This is a case of lymphadenopathy because I have put the extra likewise, right? So the example, prominent hilar vessels in a heart failure patient indicates pulmonary edema. Okay, that is how we assess pulmonary vessels. Now talk about pleural spaces. We will talk about pleural spaces. So in pleural spaces, we assess effusion and pneumothorax. So effusion, it has blunted costophrenic angles and meniscus sign actually. So costophrenic angle is the angle made by these ribs and then the diaphragm. This is costophrenic angle. So this is sharp in here, but here is the pleural effusion, right? This is extensive pleural effusion. So here is blunted costophrenic angles, and also this is a meniscus. This is forming a meniscus like this. Can you see it? This is forming a meniscus, right? So meniscus sign and blunted costophrenic angles mean effusion. So a right-sided effusion in a heart failure patient shows a meniscus sign, right? So let's talk about pneumothorax. We have talked about it earlier too. Lung collapse with a visible pleural line. You can see the same figure is here. There is a lung collapse with visible pleural line. And also a left-sided, like tension pneumothorax shows mediastinal shift. This is the deviation here. A left-sided pneumothorax with tracheal deviation, right, is a medical emergency. So that is how we finish our B portion. We have finished our A airway, B breathing, and now we are going to C circulation, where we talk about heart, mediastinum, and great vessels. Okay, so heart size and shape. How do we measure heart size or shape? How do we say if there is cardiomegaly or not? So we have to measure the cardiothoracic ratio actually. What is cardiothoracic ratio? This is the maximum diameter of a heart by maximum diameter of the thorax, right? So maximum diameter of a heart. So this is the midline. We have to measure the midline here. This is the midline. And this is the maximum dilatation of heart in left side. And this is the maximum dilatation of heart in right side. So it does not always coincide. So you like people use this ratio, like this one single ratio, but that is actually wrong. Why? Because it may not be the maximum dilatation. It's like maximum size in both sides cannot be coinciding in the same region, right? So we have to do in two different sides, like where there is maximum dilatation, and we have to add them up and divide by the entire thoracic diameter. So that is how we get cardiothoracic ratio. So in normal person, a cardiothoracic ratio is less than 50%, and cardiomegaly is greater than 50%, such as heart failure or cardiomyopathy or cardiomegaly, right? So in infants, that should be greater than 55%, and in adults, that should be greater than 50%. So example, a globular heart in dyspneic patient may indicate pericardial effusion. That is how we do heart size and shape, right? Let's talk about cardiac borders right here. So there is something called Silhouette sign. You have to remember this sign. Silhouette sign. Silhouette sign of chest X-ray indicates there is adjacent consolidation. Loss of borders is Silhouette sign actually. It should have been like this, right? It should have been like this, but there is no clear demarcation of heart border because of a consolidation here. So there is border loss, like there is loss of border. That is called Silhouette sign, and it indicates adjacent consolidation, obviously. Loss of right heart border with right middle lobe pneumonia in the same X-ray right here. It can cause like that, right? So let's talk about mediastinum. This mediastinum. So mediastinum, the normal width of mediastinum is less than 8 centimeter on PA chest X-ray. Less than 8 centimeter. Widening suggests either aortic dissection, aneurysm, or mass. Here, it should have been just like this, but this is the enlargement here. So there is the widening of mediastinum. So this happens in aortic dissection cases. What actually happens in aortic dissection? This is the aorta, and in dissection cases there is tear in the membrane, like the wall of aorta, and there is the accumulation of blood. In these cases, it can occur mediastinal widening, and in aneurysm cases, like this is aorta, and then there is weakening of certain part, like permanent dilatation. That is why can there be mediastinal widening, and also in masses, if there is some mass, it can cause mediastinal widening. So widened mediastinum in chest pain patient requires urgent CT for dissection. So that is how we assess mediastinum. Let's talk about great vessels. So I have talked about it earlier, like aortic nerve. Here you can see aortic nerve that is less than 3 centimeter in normal situations, and also pulmonary artery. That the dilated pulmonary artery suggests pulmonary hypertension. This is a case of dilated pulmonary artery, like main segment, right? That suggests hypertension, pulmonary hypertension. This is a major finding of pulmonary hypertension. You have to remember this clinically. And a prominent aortic nerve in an elderly patient may indicate an aneurysm. In elderly patient, it may indicate aneurysm because the walls of blood vessels are progressively weakened as we age, right? So that is how we do the circulation. We have completed our airway, breathing, circulation. Now it's the turn for diaphragm. So we have to assess the diaphragm shape first, and then position, and then soft diaphragmatic areas. So let's talk about shape. Normal diaphragm is dome shaped, right? Dome shaped is like this. Normal diaphragm is dome shaped, and also right is higher than left because of liver. The liver is present in right side of the body, and that pushes diaphragm a little bit upwards, right? That is why right diaphragm is little higher than left diaphragm. And flattening of diaphragm suggests COPD, chronic obstructive pulmonary disease. There can be flattened diaphragm like this. Here you can see flattened diaphragm. And elevation suggests paralysis or subdiaphragmatic pathology. Like if there is something below this diaphragm, that can cause elevation of the diaphragm, and also the paralysis, that is phrenic nerve damage, can cause elevation of diaphragm, right? So example is a flattened diaphragm in smoker with dyspnea such as emphysema, right? This is the normal position that should have been, but it is not here. And we can measure if the diaphragm is flattened or not by measuring the mid-clavicular lines first, and then assessing it, right? So that is how we do the shape analysis, and then the position analysis. Costophrenic angles It is sharp in normal X-ray. Blunting indicates effusion. We had talked earlier. This is sharp. This is blunting. In effusion cases, bilateral blunted angles in nephrotic syndrome patients suggest pleural effusions. It can cause bilateral blunting that can happen in nephrotic patients, right? So let's talk about subdiaphragmatic area. In that cases, we have to look for free air as in pneumoperitoneum, crescent sign under right diaphragm, and also gastric bubble in left side. Gastric bubble in left side, right? This is the fundus area. There is always a gas in here in normal X-ray too. But if there is a gas like this in our in our right sided, then free air under the right diaphragm in abdominal pain patient suggests perforated viscous. We have to take this very seriously. If the air bubble is present in the right diaphragm, below the right diaphragm, that suggests perforated viscous or intestinal perforation, that we have to take very seriously, and it is like urgent surgery is required in that case. So we have completed A, B, C, D, and E is everything else. What we belong to, like what belongs to everything else, that bones, soft tissues, and devices. So let's do the bones first. We have to check ribs, clavicles, spine, and shoulders for fractures, lytic lesions or metastases, and then deformities like scoliosis. Here you can see the rib fracture is there, right? Here are rib fractures, and if there is clavicle fracture, you can see here. If there is any spine abnormalities, you can see here, right? And also in here. And lytic lesions can also be seen. Deformities like scoliosis can be seen in X-rays very clearly. I have not put it down in here because it will be too much. You can search it yourself because okay, that is your homework too. So a lytic lip region in cancer patient suggests metastasis, right? So let's talk about soft tissues. So we have to look for subcutaneous emphysema right here. This is the skin. This is the skin, and this is the thorax, right? But there is emphysema like this. This is a very huge emphysema, and that is subcutaneous, right? And in that cases, you have to look for soft tissues like radiolucent streaks, breast tissue symmetry, and or masses. We have to look for that. And in example, subcutaneous emphysema in a trauma patient such as pneumothorax or tracheal injury. That is how we assess. Now talk about devices. This here, you can see a pacemaker, right? This pacemaker is for a heart. An X-ray can show the pacemaker. Confirm placement of endotracheal tubes, central lines, or chest tubes, or pacemakers. Right? Endotracheal tubes are actually 3 to 4 centimeters above carina, and an endotracheal tube below the carina risks right main stem intubation. You have to remember this too. This is the clinical part. So that is how we complete our ABCDE approach of systematic interpretation. So I hope you get it. Now in 3, we do the common pathologies, high yield X-ray findings. Okay, so this is for you, like in USMLE. So in pneumonia cases, you can see lobar consolidation and air bronchograms. An example case is a 40-year-old male or female with fever, cough, right lower lobe opacity with air bronchograms. We have to treat with antibiotics and follow up in 4 to 6 weeks. And in pneumothorax, there is pleural line and absent lung markings. 25-year-old tall male with sudden chest pain and left-sided lucency. Insert chest tube if large or symptomatic, right? In pleural effusion, there is meniscus sign and blunted costophrenic angles. 55-year-old with heart failure and bilateral effusions, right? We have to optimize diuretics, consider thoracentesis if the lesion is large. And in heart failure, cardiomegaly, pulmonary edema, that is Corley B lines or perihilar haziness can occur. Example, a 70-year-old with dyspnea, cardiothoracic ratio greater than 60% that indicates cardiomegaly, and bat wing edema. We have to start furosemide and order an echo. So in lung cancers, there can be solitary nodular mass or multiple nodules and also speculated margins. A 60-year-old smoker with a 2 centimeter left upper lobe nodule, we have to order CT and biopsy for staging of the cancer. And in COPD, it can have hyperinflation or flattened diaphragm and also bullae. A 50-year-old smoker with 12 posterior ribs and flattened diaphragm indicates the COPD. So we have to use like prescribed bronchodilators. We have to check the pulmonary function test, right? And in tuberculosis, apical cavitations can be there, and also hilar lymphadenopathy. Example, a 30-year-old with night sweats and apical cavitary lesions. We have to start RIPE therapy. This is in dots, right? Rifampicin, isoniazid, and that is how ethambutol. I forgot what is P. I'm so sorry. And we have to confirm with sputum acid fast bacilli, right? Okay, pyrazinamide, I remember it. And now this is higher X-ray signs for USMLE Pol 2. So Silhouette sign, we have talked about it. Loss of heart or diaphragm border localizes pathology, right middle lobe pneumonia. And curly B lines, short horizontal lines in lung periphery indicate pulmonary edema. And curly B lines indicate pulmonary edema. And then bat wing edema indicates perihilar haziness in heart failure. Tree inboard sign is present in endobronchial speed as in TB and bronchiectasis, and tension pneumothorax, they are present in tracheal deviation. Mediastinal shift is in emergency, it is a case of emergency. And pneumoperitoneum, free air under diaphragm, it is a surgical emergency. These are specific findings, right? So that is how we complete our X-ray findings, X-ray, how to read a chest X-ray. I hope this helped you a lot, and thank you for staying with me. Subscribe for more clinical polls and clinical sessions like this, and share the video if you found it like helpful for you. Thank you.